Hello, and welcome back to another chapter of Advanced Pharmacology. Today we're talking about Chapter 6, the individual variations in drug responses. In this chapter, we discuss the major factors that can cause one patient to respond to drugs differently from another. With this information, you will be better prepared to reduce individual variations in drug responses, thereby maximizing the benefits of treatment and reducing the potential for harm. Body weight and composition. The intensity of the drug or the intensity of the response to a drug is determined in large part by the concentration of the drug at its site of action. The higher the concentration, the more intense the response. Therefore, body size can be a significant determinant of a drug's effect. If we give the same dose to a small person and a large person, the drug will achieve a higher concentration in the small person and therefore will produce a much more intense effect. The potential consequences are that we will produce toxicity in the smaller person and potentially undertreat the larger person. To compensate for this potential source of individual variation, the size of the patient should be considered when prescribing drug dosages. Adjustments in dosage are typically based on the body surface area, because surface area determinations account not only for the patient's weight, but also for the patient's relative amount of body adiposity. Because percentage of body fat can change drug distribution, and because altered distribution can change the concentration of the drug at its site of action, dosage adjustments based on the body surface area provide a more precise means of controlling drug responses than do adjustments based on weight alone. Age. Drug sensitivity varies with age. Infants and older adults are especially sensitive to drugs. In the very young patient, heightened drug sensitivity is the result of organ immaturity. In an older adult, heightened sensitivity results largely from the decline in organ function. Other factors that may affect sensitivity in the older age adult are the presence of multiple comorbidities and treatment with multiple drugs. The clinical challenge created by heightened drug sensitivity in very young or in older adult patients is the subject of Chapter 8 and 9. So, the pathophysiology. Physiologic alterations can modify drug responses. For pathologic conditions in response are particular, may have a profound effect. The first, kidney disease. The second being liver disease. The third, an acid-base imbalance. And lastly, the altered electrolyte status. So speaking specifically on kidney disease can reduce drug excretion, causing drugs to accumulate in the body. If dosage is not lowered, drugs may accumulate to a toxic level. Accordingly, if a patient is taking a drug that is eliminated by the kidneys, and if renal function starts to decline, dosage must be decreased. Liver disease. Similar to kidney disease, liver disease can cause drugs to accumulate. This occurs because the liver is the major site of drug metabolism. Therefore, if liver function starts to decline, the rate of metabolism will also decline, causing drug levels to climb. Accordingly, to prevent accumulation to toxic levels, dosage of drugs eliminated through the hepatic metabolism must be reduced or discontinued if liver disease starts to develop. Your acid-base imbalance. By altering the pH partitioning, again, this was discussed in Chapter 4, changes in acid-base status can alter the absorption, distribution, metabolism, and the excretion of drugs. Because of pH partitioning, if there is a difference in pH on two sides of the membrane, a drug will accumulate on the side where the pH most favors its ionization. Because acidic drugs ionize in alkaline media, acidic drugs will accumulate on the alkaline side of the membrane, and conversely, basic drugs will accumulate on the acidic side. Altered electrolyte status. Your electrolytes, your potassium, sodium, calcium, magnesium, and phosphorus, have important roles in the cell physiology. Consequentially, when electrolyte levels become disturbed, multiple cellular processes can be disrupted. Excitable tissues, your nerves and muscles, are especially sensitive to alterations in electrolyte status, given that disturbances in electrolyte balance can have widespread effects on cell physiology. We might expect that electrolyte imbalances would cause profound and widespread effects on responses to drugs. However, this does not seem to be the case. Examples in which electrolyte changes have a significant effect on drug responses are relatively rare. An exception is digoxin in the presence of hypokalemia. When a potassium level is low and the ability of digoxin to induce dysrhythmias is greatly increased, accordingly, all patients receiving digoxin must undergo regular measurement of serum potassium to ensure that levels that remain within a safe range. Tolerance. Tolerance is decreased responsiveness to a drug as a result of repeated drug administration. Patients who are tolerant to a drug require a higher dose to produce effects equivalent to those that could be achieved with a lower dose before the tolerance began. There are three categories of drug tolerance: the pharmacodynamic tolerance, the metabolic tolerance, and a tachyphylaxis. So we'll speak on each of those specifically. Pharmacodynamic tolerance, which means to the familiar type of tolerance associated with long-term administration of a drug such as morphine and heroin. Your pharmacodynamic tolerance is the result of adaptive processes that occur in response to chronic receptor occupation. Because increased drug levels are required to produce the same effective response, the minimum effective concentration of a drug becomes abnormally high. The metabolic tolerance. Metabolic tolerance is defined as a tolerance resulting from the accelerated drug metabolism. This form of tolerance is brought about by the ability of certain drugs, for instance a barbiturate, to induce synthesis of hepatic drug metabolizing enzymes, thereby causing rates of drug metabolism to increase. Because of increased metabolism, dosage must be increased to maintain therapeutic drug levels. Unlike pharmacodynamic tolerance, which causes the MEC to increase, metabolic tolerance does not affect the MEC. Tachyphylaxis. Tachyphylaxis is a reduction in drug responsiveness brought on by the repeated dosing over a short time. This is unlike pharmacodynamic tolerance and metabolic tolerance, which takes days or longer to develop. Transdermal nitroglycerin provides a good example of a tachyphylaxis. When nitroglycerin is administered using a transdermal patch, its effects are lost in less than 24 hours if the patch is left in place around the clock. This will be discussed further in Chapter 43, the loss of the effect from a depletion of a cofactor required for nitroglycerin to act. When nitroglycerin is administered on an intermittent schedule rather than a continuous, the cofactor can be replenished between doses and no loss of effect will occur. Bringing us to the placebo effect. The placebo effect. A placebo is devoid of intrinsic pharmacologic activity. Therefore, any response that the patient may have to a placebo is based solely on the patient's physiologic reaction to the idea of taking a medication, and not to any direct physiologic or biochemical action of the placebo itself. The primary use of the placebo is as a control preparation during a clinical trial. In pharmacology, the placebo effect is defined as that component of a drug response that is caused by physiologic factors and not by a biochemical or physiologic property of the drug. It is widely believed that with practically all medications, some fraction of the total response results from the placebo effect. Although placebo effects are determined by physiologic factors and not psychologic and physiologic responses to the inactive placebo, the presence of a placebo response does not imply that a patient's original pathology was imaginary. Not all placebo responses are beneficial. If a patient believes that a medication is going to be effective, then placebo responses are likely to help promote recovery. Conversely, if a patient is convinced that a particular medication is ineffective or perhaps even harmful, then placebo effects are likely to detract from his or her progress. Because the placebo effect depends on the patient's attitude towards medicine, fostering a positive attitude may help promote beneficial effects. In this regard, it is desirable that all members of the healthcare team present the patient with an optimistic but realistic assessment of the effects that the therapy is likely to produce. Variability in absorption. Both the rate and extent of drug absorption can vary among patients. As a result, both the timing and the intensity of responses can be changed. It's bioavailability. The term bioavailability refers to the amount of active drug that reaches the systemic circulation from its site of administration. Different formulations of the same drug can vary in bioavailability. Factors such as tablet disintegration time, enteric coatings, and sustained release formulations can alter bioavailability and can thereby make drug responses variable. Differences in bioavailability occur primarily with oral preparations rather than parenteral preparations. Fortunately, even with oral agents, when differences in bioavailability do exist between preparations, those differences are usually so small that they lack clinical significance. Differences in bioavailability are of greatest concern for drugs with a narrow therapeutic range, because with these agents, a relatively small change in drug level can produce a significant change in response. A small decline in drug level may cause therapeutic failure, whereas a small increase in drug level may cause toxicity. Under those conditions, differences in bioavailability could have a significant effect. Individual causes of variable absorption. Individual variations that affect the speed and degree of drug absorption affect bioavailability and can thereby lead to variations in drug responses. Alterations in gastric pH can affect absorption through the pH partitioning effect. For drugs that undergo absorption in the intestine, absorption will be delayed when gastric emptying time is prolonged. Diarrhea can reduce absorption by accelerating transport of drugs through the intestine. Conversely, constipation may enhance absorption of some drugs by prolonging the time available for absorption. The genetic and pharmacogenetics, or genomics. A patient's unique genetic makeup can lead to drug responses that are qualitatively and quantitatively different from those of the population at large. Adverse effects and therapeutic effects may be increased or reduced. Idiosyncratic responses to drugs may also occur. Pharmacogenomics is the study of how genetic variations can affect individual responses to drugs. Although pharmacogenomics is a relatively young science, it has already produced clinically relevant information that can be used to enhance therapeutic effects and reduce harm. As a result, genetic testing is now done routinely for some drugs. In fact, for a few drugs, such as meroviric and trastuzumab, the FDA now requires genetic testing before its use, and for a few other drugs, including Coumadin and carbamazepine, or Tegretol. Genetic testing is recommended but not required. In the discussion that follows, we look at ways in which genetic variations can influence an individual response to drugs, and then indicate how pharmacogenomics tests may be used to guide their treatment. So here are some examples of how genetic variations can affect drug responses. It's a good spot to hit pause if you're unfamiliar with different types of variations. Genetic variants that alter drug metabolism. The most common mechanism by which genetic variants modify drug responses is by altering drug metabolism. These gene-based changes can either accelerate or slow the metabolism of many drugs. The usual consequence is either a reduction in benefit or an increase in toxicity. For drugs that have a high therapeutic index, altered rates of metabolism may have little effect on the clinical outcome. However, if the therapeutic index, or TI, is low or narrow, then relatively small increases in drug levels can lead to toxicity, and relatively small decreases in drug levels can lead to therapeutic failure. In these cases, altered rates of metabolism can be significant. The following examples show how a genetically determined variation in drug metabolism can reduce the benefit of therapy. So, variants in the gene that codes for cytochrome P450 2D6 or CYP2D6 can greatly reduce the benefits of tamoxifen, a drug used to prevent breast cancer recurrence. Here's how. To, here's how. To work, tamoxifen must first be converted to its active form, endoxifen, by CYP2D6. Women with an inherited deficiency in CYP2D6 gene cannot activate the drug well, so they get minimal benefit from treatment. In one study, the cancer recurrence rate in these poor metabolizers was 9.5 times higher than in good metabolizers. So who are the poor metabolizers? Between 8 and 10% of women of European ancestry have gene variants that prevent them from metabolizing tamoxifen to endoxifen. At this time, the FDA neither requires nor recommends testing for variants in the CYP2D6 gene. However, a test kit has become available. Variants of the gene that codes for CYP2C19 can greatly reduce the benefits of Plavix, a drug that prevents platelet aggregation. Similar to tamoxifen, Plavix is a prodrug that must undergo conversion to an active form. With Plavix, the conversion is the catalyzation via CYP2C19. Unfortunately, about 25% of patients produce a variant form of the enzyme, CYP2C19-2. As a result, these people experience a weak antiplatelet response, which places them at an increased risk for a stroke, myocardial infarct, and other cardiac events. People with this genetic variation should use a different antiplatelet medication. Among the Americans of European heritage, about 52% metabolize isoniazid, a drug for tuberculosis, relatively slowly, and 48% metabolize it rapidly. Why? Because owing to the genetic differences, these people produce two different forms of N-acetyltransferase 2, the enzyme that metabolizes isoniazid. If dosage is not adjusted for these differences, the rapid metabolizers may experience treatment failure, while the slow metabolizers may experience toxicity. About 1 in 14 people of European heritage have a form of CYP2D6 that is unable to convert codeine into morphine, the active form of codeine. As a result, codeine cannot relieve pain in these individuals. The following examples show how a genetically determined variation in drug metabolism, however, can lead to an increase that causes drug toxicity. So, variants in the gene code for CYP2C9 can increase the risk for toxicity from Coumadin, and that toxicity would be bleeding, an anticoagulant with a very narrow TI. Bleeding occurs because warfarin is inactivated by CYP2D9, and patients with altered CYP2D9 genes produce a form of the enzyme that metabolizes warfarin slowly, allowing it to accumulate to a dangerous level. To reduce the bleeding risk, the FDA now recommends that patients be tested for variants of the CYP2C9 gene. It should be noted, however, that in this case, outcomes using expensive genetic tests are no better than outcomes using cheaper traditional tests, which directly measure the effects of warfarin on coagulation. Variants in the gene that codes for a thiopurine methyltransferase can reduce the TPMT activity and can thereby delay the metabolic inactivation of two thiopurine anti-cancer drugs, thioguanine and mercaptopurine. As a result, in patients with the inherited TPMT deficiency, standard doses of thiopurine or mercaptopurine can accumulate to high levels, posing a risk for potentially fatal bone marrow damage. To reduce this risk, the FDA recommends testing for a TPMT variants before using either medication. Patients who are found to be TPMT deficient should be given these drugs in a reduced dose. In the US, about 1% of the population produces a form of a dihydropyrimidine dehydrogenase that does a poor job of metabolizing fluorouracil, a drug used to treat cancer. Several people with this inherited difference, while receiving standard doses of fluorouracil, have died from a central nervous system injury owing to the accumulation of the drug to a toxic level. So, genetic variants that alter drug targets. Genetic variations can alter the structure of drug receptors and other target molecules and can thereby influence drug responses. These variants have been documented in normal cells and in cancer cells and viruses. Genetic variants that affect drug targets on normal cells are illustrated by the two examples. So, variants in the genes that code for the beta-adrenergic receptor produce receptors that are hyperresponsive to activation, which can be mixed blessing. The bad news is that in people with hypertension, activation of these receptors may produce an exaggerated increase in blood pressure. The good news is that people with hypertension, blockade of these receptors will therefore produce an exaggerated decrease in blood pressure. The population studied indicate that variant beta-1 adrenergic receptors occur more often in people of European ancestry than in people of African ancestry, which may explain why beta blockers work better on average against hypertension in people with light skin than in people with dark skin. The anticoagulant Coumadin works by inhibiting vitamin K epoxide reductase complex 1, your VKORC1. Variant genes that code for VKORC1 produce a form of enzyme that can be easily inhibited, and therefore anticoagulation can be achieved with low Coumadin doses. If normal doses are given, anticoagulation will be excessive and bleeding could result. To reduce that risk, the FDA recommends testing for variants in the VKORC1 gene before Coumadin is utilized. Genetic variants that affect drug targets on cancer cells and viruses are illustrated by the next three examples. So, the first one being trastuzumab, that is used for breast cancer, only works against tumors that overexpress the human epidermal growth factor receptor type 2, also known as HER2. The HER2 protein, which serves as a receptor for hormones that stimulate tumor growth, is overexpressed in about 25% of breast cancer patients. The overexpression of HER2 is associated with a poor prognosis, but also predicts a better response to trastuzumab. Accordingly, the FDA requires a positive test result for HER2 overexpression before trastuzumab can be used. The next medication is cetuximab. Cetuximab is used mainly for metastatic colorectal cancer, which only works against tumors that express the epidermal growth factor receptor, or EGFR. All other tumors are unresponsive. Again, according to the FDA, this requires evidence of the EGFR expression of the drug is to be used. And lastly, maraviroc. Maraviroc is a drug for HIV infection, which works by binding with a viral surface protein known as chemokine receptor 5, or CCR5, which certain strains of HIV require for entry into immune cells. HIV strains that use CCR5 are known as being CCR5 tropic. If maroviric is to be of benefit, patients must be infected with one of these strains. Accordingly, before maroviric is used, the FDA requires that testing be done to confirm that the infecting strain is indeed CCR5 tropic. Genetic variants that alter the immune response to the drug. Genetic variants that affect the immune system can increase the risk for severe hypersensitivity reactions to certain drugs. We do have two examples here. The first being carbamazepine, or Tegretol, used for epilepsy and bipolar disorder, which can cause life-threatening skin reactions in some patients, specifically patients of Asian ancestry, who carry genes that code for an unusual human leukocyte antigen, also known as the HLA-B 1502. Although the mechanism underlying toxicity is unclear, a good guess is that the interaction between the HLA-B 1502 molecules and carbamazepine, or a metabolite, can trigger a cellular immune response. To reduce this risk, the FDA recommends that patients of Asian descent be screened for the HLA-B 1502 gene before carbamazepine is used. If the test is positive, the medication should be avoided. The other scenario, or the other example, is abacavir, or Zygen, which is again used for HIV infections, can cause the potential fatal hypersensitivity reaction in a patient who have a variant gene that codes for HLA-B5701. According to the FDA, the recommendation screening for the variant gene before using this drug. If the test again is positive, the medication should be avoided. In the future, pharmacogenomics analysis of each patient may allow us to engage in revolutionary personalized medicine that addresses the individual patient's genotype. For the present, however, although many advances have been made in pharmacogenomic knowledge, the science is still relatively new. Nevertheless, the rapid expanse of knowledge in this area is astonishing. So you can take a look at the following table here for resources to help you keep abreast of changes in this field. So I'll actually let you hit pause here so you can see several different websites where you can take a look at that. Gender and race-related variations. Gender and race-related differences in drug responses are ultimately genetically based. Our discussion for pharmacogenomics continues with a focus on these important topics. So we'll start with gender. Men and women respond differently to the same drug. A drug may be more effective in men than in women, or vice versa. Likewise, adverse effects may be more intense in men than in women, and again, vice versa. Unfortunately, for most drugs, we do not have an adequate knowledge about gender-related differences, because before 1997, when the FDA pressured drug companies to include women in trials of new drugs, essentially all drug research was done on men. Since that time, research has demonstrated that significant gender-related differences really do exist, and there are four major examples. When used to treat heart failure, digoxin may increase mortality in women, while having no effect on mortality in men. Alcohol is metabolized more slowly by women than by men. As a result, women who drink the same amount as men will become more intoxicated. Certain opioid analgesics are much more effective in women than in men, and as a result, pain relief can be achieved by a much lower dose in most women. Quinidine causes a greater QT interval prolongation in women than in men. As a result, women given the drug are more likely to develop torsades de pointes, which is a potential fatal cardiac dysrhythmia. Although there is still a lack of adequate data related to drug effects in women, Information generated by these drug trials, coupled with current and future trials, will permit drug therapy in women to be more rational than is possible today. In the meantime, clinicians must keep in mind that the information currently available may fail to accurately predict responses in female patients. Accordingly, clinicians should remain alert for treatment failures and unexpected adverse effects. Race. In general, race is not very helpful as a basis for predicting individual variation in drug responses. To start with, race is nearly impossible to define. Do we define it by the skin color and other superficial characteristics, or do we define it by group genetics? If we define race by skin color, how dark must the skin be? For example, to define a patient as black. On the other hand, if we define race by a group of genetics, how many ancestors of African heritage must be a patient have to be considered genetically black? And what about most people whose ancestry is ethnically heterogeneous, such as your Latino population? This all represents a mix of ethnic backgrounds from 3 continents. That we really care about is not race per se, but rather the specific genetic and physiosocial factors shared by many members of an ethnic group, which can influence your drug response. Armed with this knowledge, we can identify group members who share those genetic and physiologic factors and tailor drug therapy accordingly. Perhaps more importantly, application of this knowledge is not limited to members of the ethnic group from which the knowledge arose, but we can use it in the management of all patients, regardless of ethnic background. How can this be? Owing to ethnic heterogeneity, these factors are not limited to members of any one race. Therefore, when we know about a factor, we can screen all patients for it, and if it's present, adjust drug therapy as indicated. This discussion on race-based therapy would be incomplete without mentioning Bidal, a fixed-dose combination of 2 vasodilators, your isozabide and hydralazine, both of which have been available separately for years. However, in 2005, Bidal became the first drug product approved by the FDA for treating members of just one race, specifically your African Americans. Approval was based on the result of the African American heart failure trial, which showed that in self-described black patients, adding ISDN plus hydralazine to standard therapy of heart failure reduced mortality by 43%, which is a very impressive and welcome result. So does Bidal benefit African Americans more than any other American? We don't know that for certain. Only the patients of African ancestry that were enrolled in this program, so the comparison can't be made. The bottom line, even though Bidal is approved for treating a specific racial group, there is no proof that it would not work just as well or even better in the same other groups. And finally, comorbidities and drug interactions. Individuals often have 2 or more medical conditions or disease processes. When this occurs, drugs taken to manage one condition may complicate the management of another condition. As an example, if a patient who has both asthma and hypertension is prescribed a non-selective beta-adrenergic antagonist or a beta blocker to control blood pressure, this may worsen the patient's asthma symptoms if the dose is sufficient to cause airway constriction. This illustrates the necessity for the provider to consider the whole patient, not only the disease being treated, when selecting a patient's specific drug therapy. Because patients with comorbidities often take multiple medications, there is an increased likelihood of drug interaction. Drug interactions can be an important source of variability. The mechanism by which one drug can alter the effects of another and the clinical consequences of drug interactions are discussed further in Chapter 4. And that completes our chapter here for today. I thank you as always for listening, and I'll see you at the next chapter. Till then, take care.